These have been held in May of each year before this, but this year the Navy had a superb safety conference scheduled, and we really didn't want to be in conflict with that, so we delayed the quality forum to this point. And it's such an important event, and the safety symposium is also that we didn't want to not have optimal attendance for both. So we really applaud the Navy's efforts to initiate these symposiums and safety that have been such a contribution to our community, and their participation in all of the other quality and patient care activities in our community. As you recall, last year at this event, Captain Welling announced with the other CEOs in a press conference the Rational Prescribing of Controlled Substances program, which is a really very unique opportunity to improve access to appropriate care and avoid some of the abuses of prescription that has been occurring in our state. And of course, legislation helped with that as well. But the collaboration between our emergency rooms and these safety efforts has been a very wonderful thing for our community and the patients of our community, of course. The 207 conference indicated that collaboration was one of the things they thought most important for our growth as a region of medical excellence and a focus on quality and safety. And for that reason, the quality officers got together, as I mentioned before, formed a collaboration and initiated these quality forums and these other activities. One of the major quality issues is communication. It's the major issue in medical errors and unhappiness of medical staff and patients, other professionals. So it's something that needs addressing very seriously. We were very fortunate in the community that there was a communication program in operation at the Mayo Clinic with Dr. Bill Maples and Dr. Wes Paul and Ms. Terry Venezuela as leaders of those programs. They're all here with you today. And Dr. Maples has now moved to Mission Health in Asheville, where he's vice president for quality there. So we had a wonderful critical mass that institutions to normally be considered competitive have collaborated in an extremely positive fashion. We've also been very fortunate that, as I mentioned earlier, the Arthur Vining Davis Foundation gave one of their 2 grants in Florida of all times towards this program. The Department of Defense was very helpful, and the Riverside Hospital Foundation has been extraordinarily helpful in not only last year in this, but next year as well. So we're very pleased to have Lori DeJani and Catherine Boehm and Katie Towers and Tommy Platt here, who are all members of that board. Welcome, and thank you so much for being with us. Communication, as Jamie will tell us, is something that often isn't there when we think it is, and that's certainly the case in the saying if a man's looking for a little more spice in life, he's not talking about oregano. So communications is a very complex issue, and addressing it in a professional manner that has meaningfulness, positive outcomes, has been challenging for a long time. But we have a group that has made more progress in this than anyone I know, and so it's a great pleasure to introduce Bill Maples, who has contributed so much to the development of the collaborative, the forums, and certainly foremost the communication course, the patient-centered caring communication course. Welcome, Bill.
Yeah, thanks, Yank. And it's always good to be back and visit colleagues in Jacksonville. We just heard a couple hours of some sobering information, some challenges, some daunting challenges, and we had one excellent question from the audience: is what can we do, and how do we do this, and how do we really find our way to keeping our institutions successful, and most importantly, what each of us come to work every day for is to really take care of patients when they are in need. We have an obligation to figure out that how, and it was nicely outlined in Dr. Wilson's talk. If you looked at the future, number 3, and I might ask Dr. Wilson to move it up to number 1, is really focusing on quality and service and redesign of our healthcare system. Moving forward rapidly, Mr. Burkhart, embedded in his comments, were were significant pearls of just what we need to do, and that is really redesigning the way we give care. And that's really paying attention to quality, and that's really putting our heart and souls behind it. And some of the examples were extending hours, extending access points, decreasing the emergency room admissions from 120,000 to 70,000, all to be able to have the resources to take care of each and every one of us when we come in need of health care. So that turns me to the next keynote address, and I'm delighted to introduce Miss Elizabeth Boehm to talk to us about the patient experience. And as we go through the next sessions, we are certainly going to have an opportunity, and we want the opportunity to get input from each and every one of you on what you can do. How can we contribute as a community to really make these efforts successful? So the question that we really need to address is, how does patient experience and a focused effort on that really contribute to the how of helping us fix the bigger problem? So Liz is going to help us begin that conversation. And I want to read one sentence to you in terms of just a brief introduction. It says, Liz's life work is to restore the dignity and respect to the healthcare experience. Liz's life work is to restore the dignity and respect to the healthcare experience. There's not too many speakers that I can introduce that really have that as their life focus, as their mission. She comes to us as the director of the Patient Experience Collaborative at Experia Health, whose sole existence is to really address this piece of the puzzle. Prior to that, she was director of the Global Healthcare Research at Forrester Research and has extensive experience in the way consumers use healthcare, the access, the technology, and the whole transformation, which is what we're talking about in terms of really the how to address the significant problems that were outlined here in front of us. Now, I had the opportunity to really work with Liz, really hand in hand 2 weeks ago, because my own hospital where I'm at is facing the same problem with 72% Medicare, Medicaid, and that's been that way for the number of years, and they've had no choice but to find a way to work through this. But we realized, even with all of the tremendous efforts and their ability to sustain that we have more challenges coming ahead of us. So we're in a process of what we call value stream mapping every single major service line that we're doing. And Liz walked with our team side by side, looking at, as we take waste out and we redesign, and I think Dr. Rupp mentioned there's 30% waste. I think that's an estimate that's probably too low. When you really look at what's happening in your healthcare institutions, it's more like 40 to 50%. Think about that. There's an abundance of opportunity there. So Liz walked side by side with us as we were looking at ways to improve process. What about the patient experience? And as we're taking things out, what do we put back in to restore that human dignity and have always events? We talk about never events, things that should never happen. We should never do wrong site surgery. But what do you want as a patient? What do you expect to always happen when you come for surgery or when you come for medical care? And how can we restore that as we're stripping away the waste? So with no further ado, I introduce Elizabeth Boehm to really help us start this discussion, and then we'll look at what our community has done to move this forward. Liz.
Thank you all. I realize you've been staring at this face for quite some time. And as you can tell, I'm normally a pretty big smiler, but I feel a little bit like I'm in the hair club for men, because right now, some of you can probably see, I'm not just a patient advocate, I'm also a patient. So bear with me as I try not to do my normal big smiles. I was lucky as I went through this experience, or I count myself lucky, and I find it a little sad that I count myself lucky, that as Dr. Chally described the idea of of medicine being a joy, a privilege, and a responsibility. That I was working or being taken care of in a system and by a doctor and a set of nurses who absolutely took that to heart, who treated me with wonderful dignity and respect, addressed all of my cares and concerns, including getting on a plane 2 days after surgery, and just met me where I was at and helped me get through this experience. Unfortunately, that's not always the case. We do a lot of things in healthcare that are disrespectful, that are dehumanizing. And I spoke to a patient recently who's a chronic Crohn's disease patient, and I honestly wouldn't trade places with this man for anything. It's a very difficult illness. And he described, he's been in the hospital hundreds of times, he's seen the good, the bad, and the ugly. And he described an experience where he was in a hospital with an excellent reputation, with a bowel obstruction, and had gone through some surgeries and gone through some treatments, and ultimately came to the day of discharge. And his belly was distended, he was uncomfortable, he didn't feel well, but the clinician basically said, "It's time to go." Now, that's not the clinician's fault entirely, right? The system is saying this is how much we'll pay for, and there are all those complications that we've already heard about. But basically what this doctor ended up telling him is, you're healthy enough for discharge, but not healthy enough to go home. I suggest you check into the hotel across the street because you're going to have to come back here. Something is fundamentally broken in a system when that's what we're telling our patients. And in fact, that's what happened to Michael. He went into the hotel, woke up in the middle of the night with projectile vomiting, and had to come back in through the ED as though he had not just spent 2 weeks in that same hospital and as if they had never seen him before. That's not okay. And that's what I want to talk about. And partly it's not okay because Michael deserves a lot better. But partly it's not okay because that clinician was forced into that situation. Partly it's not okay because that's not a good use of community resources. It was a waste of his travel through the ED. We can absolutely do better. And if we look at this at a system perspective, this is basically just a different version of the slide that Dr. Wilson showed you earlier. We are spending an awful lot as a nation for, I will admit, mortality or life expectancy is not the only measure by which I want to be judged when looking at the healthcare system, but it is an overall measure. We're not necessarily getting what we're paying for. Now, that is not entirely the fault of the system. Dr. Coble talked earlier about his grandmother's wisdom, and certainly part of this picture here has to do with our culture. It has to do with our diet and lifestyle. You could argue it goes back to ag policy. I mean, it is a huge thing. Health is every decision we make all day, every day. All of you are sitting down. It's not a very healthy behavior. Many of you have had the pastries in the back of the room. Not a very healthy behavior, right? So it's every decision we make, and I'm not here to say that, smiling and treating patients nicely is the sole solution, but it is absolutely part of the solution. And so let's look at how that breaks down within the health system. Now, I've never met anybody, and I've worked with insurers, I've worked with hospitals and systems, I've worked with clinics, and I've worked with life sciences firms. I've never met anybody who didn't believe fundamentally that their job was to help people, to help drive the system to be better. But there's still plenty of blame to go around. If we each look at our own roles within the system, we all have responsibility and culpability for what goes wrong. And that's true of patients and families as well. Patients and families demand services they don't need. They don't comply with medical advice. I'm not supposed to have flown until Friday. So they fail to follow lifestyle guidance. They focus only on their costs instead of making decisions that might be good for the overall system. There's absolutely room for improvement there. There's also room for improvement with health professionals and systems. Right? We, health professionals, sometimes cave in to unreasonable patient demands because it's more expedient, rather than either structuring a system or taking the time to walk people through that. We practice defensive medicine. Yes, we can blame that on the tort system, but it's nevertheless something that we have allowed the system to manipulate us into. We allow organizational silos to persist, right? When the ED does not know that this man was just discharged from 2 weeks of spending time on a med-surg floor, that's a problem. We also tend to tack new checklists onto broken processes instead of starting them over. And we fail to address burnout. Frankly, medicine is a difficult profession. And I'll talk more about that. And as a system, we don't necessarily do enough to support the critical people that are caring for patients. And insurers and regulators, those are the people everybody loves to hate. They certainly treat medicine like a cookie-cutter profession. When we look at evidence-based medicine even, I don't know about you, but my chances of needing a skin cancer surgery are no longer the statistical average for my age. They are 100%. Right? So evidence-based medicine doesn't always apply to everyone. They also bully doctors and systems in inefficient processes. I've never met a health insurer that wasn't happy to take their work and put it on your plates. They allow lawyers to dictate medicine. They fail to address systemic problems. They overregulate. So there are problems throughout this system. And the more important thing, I think, is to focus on how to solve them. And one of the ways that I've seen a lot of systems approach solving it is through process improvement. And process improvement absolutely has its role. What this rather clumsy-looking graphic shows is a process around Lean and Six Sigma. Lean and Six Sigma came from the manufacturing worlds, Toyota and Motorola, where they were looking at ways to eliminate in Lean, the 7 kinds of waste, which include things like inventory, overproduction, moving things, walking, processing, motion, defects. And certainly some of those are true in healthcare. We move patients places simply because we have a piece of equipment over somewhere else. We have nurses that are running around ragged. But there are also pieces of this that just don't necessarily fit. Counting patients waiting for beds as inventory just doesn't sit right with me. On the Six Sigma front, we're looking at removing variability and defects. And absolutely, again, great role for looking at how can we practice the best medicine every time. But when we look at this, we need to focus on the pieces that we really should take out. The things that are waste, things like patients should not have to wait while a nurse goes to get supplies that are stored somewhere that doesn't make any sense. Doctors should not have to waste their time filling out duplicate paperwork. There is waste to be removed, and as Bill said, it probably is as much as 50%. But we also can't just look at this as though it were an assembly line. This is an actual survey that a doctor photocopied and sent to Experia saying, this was a patient post-heart surgery saying, no questions were asked about the psychological damage that you do with these surgeries. Go to Amazon and do a search on the subject. Last time I did it, there were 18 books. If the patient kills himself, as I almost did, but the heart is working great, is that all that matters? Are you just mechanics? And I run into doctors who increasingly feel like they're being treated like assembly line workers, not given the time or the space or the process to connect with their patients. I really think we can aspire higher as a system. You know, if you fix the muscle, if you repair the muscle but break the heart, have you really succeeded? I think we can hold ourselves to a higher standard. And that's where the concept of patient-centered care comes in. And I'm not standing here to tell you patient-centered medical home. I'm not here to tell you ACO. When I say patient-centered care, I'm talking about recognizing again that the patient and family and the care providers need to be at the center of our decision-making. So patients deserve effective, safe, and efficient care that addresses their medical, health, and emotional needs across care settings and over time. This is getting a lot more attention, and sometimes that's driven by scores, right? Things like HCAHPS, right, which ultimately is driving reimbursement. And I don't want to, you know, the discussion we had earlier about reimbursement is very, very important. But we're still spending an enormous amount of money, and there just isn't going to be more. We're going to have to figure out how to do it better. And that means recognizing that there's not always a grandmother available, that our economic and cultural systems don't always support people making the right decisions. So we've got to, that's our reality. We can either look at it and say, why is that still our reality, or function within it. So I want to unpack this a little bit and talk about what this means, because I think some of it's obvious and some of it needs a little bit more explanation and, frankly, a little bit more justification, right? This isn't just smiling, which I can't do right now. It's about a lot more than that. So let's start with effective, safe, and efficient. Many of you may recognize this picture from what's called the Miracle on the Hudson, where Captain Sully of American Airlines, which frankly I had to look up to know that it was American Airlines, but landed a plane that had sucked some birds into its engines safely on the Hudson and saved all of the patients that were on board. This was really an extraordinary event, but how many people before I said American Airlines remembered that this was American Airlines? No. Okay, a couple of you. I flew down here on JetBlue, and I flew down here on JetBlue because they've got fun staff and TVs in the back of the seats. American may well have flown. They also had a schedule that kind of worked with mine, although I got in at like 10:30 last night. I expected that if this kind of situation arose, those pilots would do what Sully did, that they would have safely landed me on the Hudson if that had been the right recourse, right? Most patients expect that they're going to get effective, safe, and efficient care, and frankly, they should be able to simply expect that from us. That is our fundamental job. One of the things that Sully said after he landed this plane on the Hudson, which I still think is extraordinary, is that's what pilots do. We land planes and we safeguard our passengers. And that is what medical professionals do. We provide effective, safe, and efficient care. So if we look at the idea of addressing a bigger picture, I think it's interesting to look at some of the domains and elements that go into providing care. So this is some work that was done by Ascension Health, building off of HCAHPS, and I realize this text is a little bit small, so let me just lay it out really quickly for you. They looked at the different HCAHPS domains, things like nurses treating you with courtesy and respect, getting things explained well, being listened to, having your pain managed, having a quiet and clean room. And they broke it down into basically 3 components. One is that safe, effective, evidence-based care, which is the clinical reputation and quality, and that's in orange. They also looked at having a coordinated, efficient process. So still, again, that effective and efficient, and that's a comfortable environment and administrative efficiency. But then a lot of the HCAHPS questions look at emotional and spiritual support, so compassionate and respectful care, communication and empowerment, and care responsiveness. And they looked at those, and they also use another measure which is known as Net Promoter Score. Now, Net Promoter Score comes from other industries, and it's basically a measure on a 0 to 10 point scale of how likely are you to recommend this company to your friends or family members. And the way that NPS is structured is if you say a 9 or a 10, you're considered a promoter. If you are that satisfied with the experience you're getting, you're likely to go out and say, this is a great place. You'll tweet about it, you'll tell your friends, what have you. If you're a 6 or below, you're a detractor. Now, a lot of people say 6. 6 is still above 5. That's above the median. Well, if I came to you and said that place where I got my surgery done, yeah, they were okay. Are you going to want to go there? No, so that's considered a detractor. And this method or this methodology and measurement has been studied across thousands of companies. There are several hospitals using it. I'm not here to say this methodology is perfect or imperfect, but what I think is interesting is that Ascension correlated HCAHPS with NPS to look at what really drives people to either really connect with a hospital or to feel like, it's okay. And so they looked at which factors within HCAHPS have the potential to anger somebody, which is really creating a detractor, and which ones have the likelihood to delight. So anger is there on the x-axis, delight on the y-axis. And so they said if anything has the potential to anger, it's critical for avoiding detractors. So for avoiding people talking smack about us, if you will. And if it's something that is likely to delight, then it's critical for promoter creation. And I would argue critical for promoter creation is one angle to look at it. The people who really you've touched in that kind of level are also the people that are likely to listen to your medical advice, who are likely to stay within your system in order to get the holistic and preventive care that you might be providing. So it's a lot bigger than just promoter. When they mapped out HCAHPS against those, and the circles here represent how much of an impact the given area has on the NPS. What they found is that the emotional elements, the communication, compassion, and care, had a much bigger impact on NPS than any of the core sort of efficiency and safety kinds of pieces. But what they also found is that communication, while critical, is not enough. It has to come with compassion. It has to come with care responsiveness. So it has to come in a way that puts the patient at the center. Now, if you ask patients, they'll tell you this in different ways as well. So this is a study from the Consumer Advisory Panel that asked consumers, in your own words, describe quality. And 65% said staff compassion. Over and above clean facility, over and above experienced medical staff, over and above updated equipment and processes. How they define quality is that connection. And especially, again, as we look at preventive care, as we look at engaging with patients across even a DRG, that ability to connect is going to be critical to keeping them on the path to wellness. And they're not wrong, actually. Studies in the New England Journal of Medicine have shown that patient satisfaction with care does correlate with quality. And my job at Experia is that I run a collaborative of hospitals that is trying to put more science behind this to understand which pieces of this really matter, what drives to better outcomes and lower cost, because this science is still relatively new and emerging. But I wanted to show it in a slightly different light because, it's easy to say we need to connect, we need to show compassion, we need to communicate clearly. I did some work, or I've done a lot of work in the technology arena, and somebody asked a technology question earlier. This was a program put forward by Kaiser Permanente, and they were doing, in their outpatient setting, a weight management program for obese consumers. And they decided to test out whether you could create a human connection in a technology environment. So when they gave this weight loss information, they offered it up in two different ways. In one way, you just got the information, and I'll show you the study design in a second because they did it as a randomized controlled trial. The other way, you got a virtual guide. Now, a virtual guide was nothing more or less than the picture of a person that you got to pick. Right? So you were getting the same information, essentially. They took 4,000 plus members, split them randomly into these two groups, and gave some of them content delivered by a fake human being, and some of them content just delivered as content. And what they found, the red line is the groups that got the fake human being, the blue line is the comparison, the red line, the balanced group, the people who had an advisor, lost more weight in this digital-only program. Not only did they lose more weight, but they had fewer outpatient visits over 6 months in the follow-up period. That is how powerful human connection is. A fake human being can engage you. And I'm not saying this because technology is the sole answer, or go ahead and fake it, just put some avatars and posters up in your hospital and you're all set. I'm saying this just to illustrate how powerful it is, and also to recognize that technology is going to have to be part of this solution. Right? We can't have the demographics that Dr. Wilson showed us with an aging population, which means not only more people accessing care, but more people retiring out of care delivery, and expect that we're not going to have to bring technology into this. So as we look at these ways to get more efficient, as we look at these new ways to deliver care, it is absolutely critical, if we want to be effective, to remember how important that human connection is. So put another way, or another element of what I just defined for patient-centered care, is that it also addresses patients' needs across facilities and over time. And I think Don Berwick put it best when he said, we owe them journeys, not fragments. Now, I have fewer examples to show you here, but certainly to the extent that places like Geisinger and Kaiser, places that are integrated systems, have had some successes, there's an indication that those connections across entities and over time has a powerful impact on people. Now, there's a group here that I haven't mentioned that's also absolutely essential, and that is clinicians, doctors, nurses. Right? Human-centered care or patient-centered care can only be delivered by well-centered and cared for humans, or the technology versions of them, as I just showed you. But we can't be running doctors and nurses ragged and expect them to be able to connect with patients in a way that is ultimately going to control costs and drive to better outcomes. There are a couple of different ways that this happens. Some of it, I think, is system inefficiency, and there's just one way to look at that is burnout. So the definition of burnout is the persistent or chronic experience of perceiving that the demands on you outstrip the resources available. Right? If you are constantly working in that environment, you're going to get burnt out. There's also secondary post-traumatic stress, which is basically the stress that you feel by being constantly exposed to other people's trauma. And all of these are issues for nurses. All of these are issues for doctors. And even, I would say, going down into the primary care setting where people are seeing diabetes poorly managed over time, that kind of thing exists. This problem is extensive. 53% of practicing physicians report moderate to severe stress. 64% of surgeons feel their work schedule doesn't leave enough time for personal and family life. I was at a hospital in Ohio the other day where one of the doctors pushed back on a story about my CEO, Bridget Duffy's father, who was a doctor, calling his patients over after dinner each night. And he said, wow, your father was lucky he got to have dinner with his family each night. This is a real and serious problem. And it leads to increased errors. The higher the emotional exhaustion among clinicians, the more errors we see. So that's the more of those dollars that we're already struggling to get that get wasted within the system. Now, traditional approaches to solve this are things like behavior coaching, disruptive programs, punitive use of satisfaction data and metrics. We actually talked to a hospital the other day where the ED had a new type of admission. They called it a PGA, a Press-Ganey admission. Press-Ganey is a common patient satisfaction measurement firm. And so the ED guys were admitting patients because they knew if they didn't, their Press-Ganey scores would be low and then the CEO would be on their backs. I mean, this is absurd, right? So there are definitely better ways to do it. This is not the all this and smile to kind of approach. So let me just walk you through a couple of different approaches that we've seen, all of which are low cost and low overhead. The first is with the San Mateo Medical Center, which is in California. Xperia is based in California. They are a safety net hospital. And they had a lot of baseline levels of emotional exhaustion, burnout, fatigue. They approached us and said, do you have anything for this? And we didn't, but we said, this seems like an important issue, let's take a look at it. We found a doctor in the community who was fascinated by this stuff, who'd done a lot of research and looking into things like mindfulness and how you use simple meditation and things like that to improve people's or limit burnout. So this program ultimately cost San Mateo no money because they reached out in their community and found some willing partners. I'm not saying that's always possible, but it happened to work in this case. What we put forward for them was some programming that measured them at baseline, gave them 2 4-hour trainings. One was just to get them bought into the idea that they had to take care of themselves and that mindfulness and meditation were not, anti-Christian Eastern ways of doing this frou-frou crazy stuff. Even Californians won't push back on some of that. So to win them over to the ideas and teach them the basic ideas, we then had them go and do some mindfulness and meditation structured homework, things like gratitude journaling one thing each day for which you're grateful, spending 2-minute meditations. We recorded those for them and sent them out to them. And they saw a significant decline in their level of emotional exhaustion. The CEO approached one of the nurses afterwards and said, how was this training? And she said, you know what, I've found my tree. And he said, what are you talking about? He said, Dr. Dinnenberg walked me through a meditation where I was to go to a tree and relax. And you know what, I can find my tree now anytime during the day when I feel exhausted and burned out. Now, we're still following the San Mateo example to see what the impact is on outcomes, but so far the satisfaction levels have been enormous. In another program that we did, a surgeon, this was more of a find your own path towards it, and a surgeon decided that what he was going to do was stop. He drove by this pond every day on his way home from work. He decided he was going to stop and take a moment every day on the way home and just leave the cares of work and let them flow into the pond and let the water wash them away. A week into this, his wife sat him down and said, are you having an affair? You seem really happy. So it can be very effective, although you have to watch out for side effects. But nevertheless, that is not, this is a behavior that is not expensive, that's not causing some dramatic, change in the programming or new policy. What it does require is a commitment and reinforcement, right? Because it's easy to get started on these. Any one of us who's ever tried to lose weight knows it's easy to start these programs. Maintaining them takes some effort, but we can do it as a system, we can do it as a community, we can do it as even sub-communities within clinics. One other example I want to give you comes from Twin Rivers Regional Medical Center, which is it's not a safety net hospital, it's part of a for-profit system, HMA, in Missouri. And they created what they call the sacred moment at admission. Now, sacred because it must always happen, and it's important to dedicate and preserve that space. But what they do is, while the normal admission process is, give me your insurance information in triplicate, right? Show me your living will. What's this? Have you understood? Have we given you all the informed consent? And this is more like informed hope. This is about finding out from people, what are your greatest fears and concerns? What spiritual resources do you need that we might be able to help you get access to through our community partnerships? Do you like the room hot or cold? Who is your point person? Who should we make sure we're coordinating with? And what they found is not only have their satisfaction scores gone up 30-40% across the board, which is more or less unheard of, from this one action, that I will grant you takes a staff member's time, so it's not no cost, but it didn't take a massive process overhaul. They've also found that this has had a significant impact on the clinicians that do it. One of the nurses gave the story of walking up to a floor to do yet another admission. She said she was tired. The language she used is, I had to dig in deep into my pocket and find my smile and walk into that patient room. And by the time she had sat down and asked these things and listened to the fears and concerns, she said, I remembered why I entered medicine in the first place. And that smile did not go back in my pocket the whole day. She realized her problems, whatever she was worried about, were nothing compared to what this gentleman was facing as he approached his surgery. So those are just some anecdotal examples, and there's more great work going on around the country. And all of this ties back to this idea of communication, this idea of connection, this idea of building respect and finding that joy that Dr. Challey talked about at the beginning. And so I know I'm what's standing between you and lunch, so I'm going to keep talking. No, I'm kidding. I'm going to wrap up pretty quickly. But as we come to the next section afterwards, we're really going to be asking you to define how can patient-centered care promote a caring community in Northeast Florida? What can you do to the woman's question over here? Individually, what can you do institutionally? What can you do as a community? Some of these things will take money. Most of these things will take time. All of them will take a commitment. But there's so much evidence that this can affect the outcomes. This can affect the joy and satisfaction that clinicians who, once they've trained, want to stay in the work because they haven't been burned out and exhausted. There's really an opportunity for you. And I know we've talked a lot about reimbursement, and we've talked a lot about all these forces that come from outside. And those forces are always going to be there. And the question is, do you wait for them to come and pull the rug out from under you? Or can you put these things in place proactively that, yes, we'll have to shift some as reimbursement changes and as the political whims shift, but that fundamentally will make your care institutions, the places people want to come to get care, the places clinicians, doctors, nurses, pharmacists want to come to work in order that you can create this caring community. So with that, I will take questions.
My greatest thought and my continuing concern is always how we get from the slideshow actually to the bedside. My experience over 20 years, just in quality, and 30 years in nursing, has been that the leaders, especially senior leaders, come to events like this, get great information, get inspired, take it back to their institutions, spread it around as much as they can. But the message goes from the senior leaders to, say, the next level of leader, but the next level doesn't get the inspiration and the information that the highest leader got. Those leaders are then responsible for getting to the next level of management, who gets even less information. As it goes from level to level in the institution, it becomes more and more like a chore, and appears to be to the person at the bedside appears to be, number one, a chore, and number two, not really applicable to what they're trying to do, which is often get as many tasks done as possible because that's the message that they're really getting. Get that work done, get those tasks done. We don't really have time for you to have mental space to think about, to have a sacred moment. Yeah. I'm really very interested in how people have overcome that in their own institutions.
So let me make a few quick comments on that. First, what you're describing is what we like to call the middle management mafia, right? They're the ones who kind of hijack the effort. But there's a couple of things. First, absolutely inspiration and commitment needs to come from the high levels. But when we work at Experia, we insist that we work with a nursing manager and a physician manager on a particular floor that we're going to be implementing these changes. The sacred moment may not be exactly what your floor needs to do, but if they create it and own it, they're often able to identify the wastes and the things that they can replace, that they can come out. So you need the commitment from the top to allow them to make those changes, but the enthusiasm and idea generation from the bottom. So that can come through things like linking your lean processes, if you're doing any lean or Six Sigma, to this experience work like Bill described, and making sure that those frontline nurses and doctors are there and are engaged. So that's one of the best ways that we've seen. We also, I'm not here to plug Experia, but one of the things we do through the collaborative is try to socialize this information, right? We make our webinars and group calls as open as we can so that you can have all levels of the organization, and we're not just talking to some administrators that are viewed as out of touch. So it's a real problem, but I think it is one that can be addressed.
I just want to ask, what in your experience has been key in moving communication forward in the healthcare sector? I do know that health literacy is an issue. How do you bridge that gap most times?
So literacy is absolutely an issue, and I think it happens on a couple of different levels. One is certainly training the staff to listen. It's one of those things we all think we can listen. And all of us are usually running through our own heads what our checklists are. I can't remember the stats, but I think the average doctor interrupts the patient within 7 seconds, something along those lines. So to listen to the language that patients are actually using and be able to mirror that back to them. So we'll hear from Mayo about some of the communication programming that they've put together, and you'll hear more about that. One of the things that I find interesting with the low literacy population particularly is BU Medical Center has done some work looking at the low literacy population, and they actually created a technology-based solution. You wouldn't think this was possible. This is an avatar. This is the ugliest avatar you've ever seen. It's not even Simpsons level cartoon kind of thing. And this woman will talk to you and she'll start out with, how about those Red Sox? I'm from Boston. But then we'll walk through the discharge instructions with some interactivity, asking people, did you understand this? What are your questions? And believe it or not, this tool has gotten, in a low literacy population, better scores than either nurses or doctors speaking to the patient in person. And the reason is the patient never feels condescended to and never feels like they daren't waste the clinician's time. Right? So I think there are ways to get creative. And again, patients are loving this. They feel like it is a very humanized experience, even though it's through technology. So looking at what are the ways we can deliver given the resources available to meet those needs. And I think we'll take one last question.
I want to continue with this technology. It's Dan Morgan, Chief of the VA, and we have actually been very technologically advanced for many years. One of the biggest challenges I have in dealing with remembering that it is the patient is that my staff tend to be focused more on the computer than the patient. And so, as we do more microbits and more data and all this other kind of stuff, technology is great and everything else, but how do you face the challenge that it's not inputting the information into the computer, but it's actually communicating with the patient, then inputting it into the computer?
Yeah, so I've seen that addressed a couple of different ways. One is, in my own experience, my clinic uses Epic and has done for the past 15 years. And the first few years, it was painful. First of all, listening to the spew of expletives that came out of the clinician's mouth as they were trying to write it was not inspirational, but as it's moved forward, they've gotten a lot more comfortable to where that computer becomes a tool for us having a dialogue about my care. So I think there is a transitional thing that happens. And if you look at Gen Xers, or well, Gen Yers really, and millennials, you probably can't talk to, you're going to have to text them anything. you're going to instruct them on anyway. So that I think will become less of an issue. But I think I've also seen some workarounds in cases where clinicians simply cannot get around and adeptly use the technology. And I worked in technology research for 15 years. Interface designers on the EMR should be shot for the most part. I mean, these things are awful. For the ones who can't work around it, I've seen models of using medical scribes. Now that does change the dynamic, and there is a cost associated with that. But I had a doctor come up to me once after I talked about that and said, nobody's ever asked me how much I would pay out of my own salary to have a scribe. So models where you might look at splitting the cost. Looking at and the productivity increases, the last study I saw, slightly higher among physicians who are using a scribe. So there are ways of working around that technology as we move through that transition period.
All great questions, and keep the. I asked to hold on to some of them because we're going to have a chance to revisit them from multiple institutions across our region of what they're doing and how it's working, and then we're going to turn the topics back to you to see how you can help us.